I welcome everyone on board here. Congratulations to our presenters for getting to this round. I know round two was incredibly enlightening and difficult, so I can't imagine how difficult this round's going to be, and I don't mean that in a passing way. So our game plan is to go in the order of your poster numbers, and that means Joytsna will be first, Daniel will be second, Rawan will be third. I'm sorry, Danny will be second. Rawan will be third. Alex will be fourth. Preston will be fifth. Michael will be sixth. And Sanjivani will be seventh by virtue of your poster numbers. And you all know 5 minutes, and Dr. Weissman's going to give you a 4-minute warning. And then we'll take 2 minutes for questions and move on. If you all would just be kind enough to say where you grew up, where you're doing your residency, your future medical plans, and then just one thing that you like to do for fun away from medicine, and then launch into your presentation. So, Joytsna, you are our leadoff hitter.
All right, great. I'm Joytsna Ghosh. I'm a second year at Bayview in internal medicine and love it there. I'm from Cleveland originally and love going for long walks in the sunshine. So I'm very happy at this time of year.
Thank you, Joytsna.
All right, and with that, I will get started. So this is a learning case about acute joint pain associated with high synovial white count. And you can advance to the next slide. Some of the big takeaways that I have from this case are that synovial fluid changes can happen because of trauma, inflammation, or infection. Although a lot of the traditional teaching is around a kind of cutoff point of synovial white count of 50,000, it's important to keep a broad differential diagnosis and consider also crystal-induced arthritides and spondyloarthritides with those higher white counts. And the second point that I want everyone to take away from this, which I think everyone knows, but always good to bring to the forefront of your mind, is that thorough history taking can really change a diagnosis. And the elements that come forward in this case really helped us to give this patient the correct diagnosis. You can advance to the next slide. All right, so this is just an algorithm that came out in 2021 this year in the Journal of Experimental Orthopedics, and it's a nice summary of the traditional approach that we take when someone has acute joint pain, has swelling, tenderness, redness, and the patient that we're going to talk about today fits in the middle category here, has a leukocytosis in the synovial fluid, has high neutrophil count in the synovial fluid. And so as you can see here, this is based on many articles and studies that have been done over the last 10 years. The likelihood ratio is very high that this person would have septic arthritis. But as the case that I'm about to talk to you about will show, it's important to take all of those elements of the history into account when you come to a final diagnosis. Okay, you can advance to the next slide and get into the case. So this was a 36-year-old woman. She came into the ED with severe left-sided hip pain. It rated to the left anterior hip. It had started the morning of her admission, and it was worse with movement to the point where she couldn't bear any weight at all. She didn't have any medical history before this, except a recent delivery of a healthy baby a couple months before. When she came into the ED, she was afebrile. She couldn't flex, abduct, or rotate her left hip. She was limited by pain. Even passive range of motion was limited. Her laboratory studies were notable for leukocytosis, 88% neutrophils, an anemia to 10.7, low iron level of 15, iron saturation of 4%, and her sedimentation rate was elevated to 39. Her CRP was 6. She got an MRI of her left hip, which showed an effusion and some enlarged lymph nodes nearby. She had joint aspiration, which showed cloudy synovial fluid and 84,000 leukocytes in that synovial fluid, as well as 91% neutrophils. No crystals, gram stain was negative, and the culture was still pending at the time when a lot of this was happening. So the presumptive diagnosis that was made was septic arthritis of the left hip. And so she was started on ceftriaxone and vancomycin. Orthopedic surgery was consulted and planned to take her the next day to the OR for operative drainage. In the couple of hours before she went to the OR, rheumatology came to see her as well and gathered a little bit more history and found out that she had had migrating joint pain in the month prior to this admission. She had had sharp pain in her right shoulder for 3 days that then moved to her left shoulder. She had taken some ibuprofen, which helped with that pain. At the same time, she had 6 dime-sized red nodules on her shin and had some stomach pain and bloody bowel movements that she hadn't thought to mention because it didn't seem associated with what had brought her into the hospital.
4 minutes have passed.
A week before her admission, she had pain in her left hip that was very similar to her presenting pain. She took ibuprofen. Over a couple of days, that pain went away to the point where she was jogging over the weekend. And so the presumptive diagnosis, based on all of these elements of history, became inflammatory bowel disease associated arthritis. The decision was made to defer surgery and instead trial ibuprofen, 400 milligrams every 6 hours. And within 24 hours, her pain was gone. And the day after that, she was able to walk home with no pain at all. She had a colonoscopy on the outpatient side, and that showed crypt distortion, ulceration, cryptitis. And so IBD was confirmed for her. And so this inappropriate, in this case, operative drainage was avoided by getting a full history. We can go to the next slide. All right. And this kind of comes back to one of the points that I'd like you to take away today, which is that, even with a white count of 50,000 to 100,000, septic arthritis is high on the differential, but there are other things that can cause that same elevated white count, like crystal-associated arthritis and spondyloarthritis.
Thank you, Georgina. And I guess with that very high white count, and granted, thank goodness for rheumatology coming along, with the white hat on.
Yes.
But certainly we see comorbid causes of arthritis, for example, crystalline plus infection. And of course, we see negative cultures for one reason or another, including antibiotics have already been started kind of thing. Mm-hmm. I mean, I guess I would have been on the fence in terms of, do we go ahead and drain this thing? And I just wonder what the thought process was there.
Yeah, absolutely. So I think that if it was just in one joint, especially even given that algorithm that I showed earlier, which is based on 10 years of studies, the likelihood ratio is so high of septic arthritis that you would be correct. It wouldn't be wrong to go to operative drainage. I think that one of the key elements here is that the full history hadn't really been obtained at that point. So with migrating arthritis, that changes the story a lot, right? And so I think then the differential kind of shifts as well. But I agree with you that, it's important to keep that high on the differential, because if it is an infection, going and getting that washed out is important.
Thank you. What questions are there out there?
And Dr. Williams, I actually have a delayed answer to your question from the last round. So I looked at the colonoscopy a little bit more closely instead of just the histology. And so she had loss of all vascularity, she had erythema, and she had ulcers that were superficial. And it was mostly in her rectum and sigmoid colon, but also in the descending colon, and spared everything above that.
Was the ileum visualized?
It was.
And it looked normal?
It was.
And including that, and I urge you to, publish. All of you, really, I think will have very worthy stories to share with the medical community, but I think those photos of the growths will add much to your presentation, Georgina. Thank you for that follow-up.
Yeah, I think Dr. Williams, your point is very well taken about, could you have two things at the same time, inflammatory bowel component, and maybe, theoretically could have translocated the bowel and caused a secondary infection or an infection of that joint. Yeah, so that, in fact, when I heard this case first, I was very interested in it, especially that last slide that she has that shows how this type of white count is, 50% or so will be septic arthritis. I think Dr. Goshen mentioned, and then, but other causes you got to think about. Yeah, having a septic joint, in addition to maybe the joint that was already inflamed because of IBD, yeah, that's a tough one, right? That's a tough one.
It is. And most of the studies that were done that have looked at this, there actually is not a minimal amount of kind of simultaneous crystal associated arthritides and septic joints. So that's not a non-entity for sure. Most of the studies that have been done, they confirmed septic arthritis with a culture and only included people who had not received antibiotics before.
Got it. Excellent.
Thank you, Joyce.
Thank you.
Danny, you're up.
All right. Hey, everyone. My name is Danny Solden. I'm an intern at the internal medicine program at University of Maryland. I'm originally from Bethesda, Maryland, and I am currently trying to make my mind up between home quick care and ID. And for fun, I've been a part of dance teams for most of my life, and so I do love to dance. Okay, so going into my case now, a little bit of background for it. Caring for post-transplant patients can be challenging, especially due to their comorbidities and polypharmacy. And dapsone is a common antibiotic prescribed in these patients for PCP and toxoprophylaxis. So I'm presenting a case of dapsone-induced methemoglobinemia and hemolytic anemia in one such patient. On the next slide is my case presentation. Our patient was a 65-year-old man with a history of bilateral lung transplants secondary to idiopathic pulmonary fibrosis, as well as CKD due to calcineurin inhibitor use, and he presented with acute on chronic dyspnea and fatigue. His O2 sat at home had decreased from around 92% to 85% over a period of weeks. He had an extensive medication list of 16 total medications, including immunosuppressants like tacrolimus, sirolimus, and prednisone, and prophylactic antibiotics like azithromycin, dapsone, and posaconazole. On presentation, his vital signs were notable for an O2 sat of 84% on room air, which rose to 94% on 3 liters nasal cannula. His physical exam was remarkable for bilateral lung crackles, 1+ edema of bilateral lower extremities, and scleral icterus with no other stigmata of cirrhosis. The rest of his exam, including his cardiac exam, was normal. On the next slide, we find the initial labs and imaging. At the time of presentation, his initial labs revealed hemoglobin of 8.1 compared to his baseline of 11 from 5 months prior. His serum creatinine was 5.8 from a baseline of 5.3. And his initial chest x-ray and chest CT, which you can see in figure 1, showed mild pulmonary edema and minimal patchy consolidations in the right upper lobe. At that point, there were multiple consultants involved, and the patient was treated for hypervolemia with diuresis and was assessed for potential transplant rejection with bronchoscopy and PFTs. Pneumonia was thought to be less likely given his atypical imaging findings. Even with diuresis, the patient's hypoxemia did not improve and his anemia continued to worsen. Given his history of dapsone use, an ABG was obtained, which you can see in figure 2, panel B. The ABG was dark in color and showed significant discrepancy in oxygen saturations between the arterial blood and the peripheral pulse oximeter. Additionally, LDH was 900, haptoglobin was undetectable, direct Coombs test was negative, and his peripheral smear showed acanthocytes, which can be seen in figure 2, panel A. His arterial methemoglobin level was 10.4%, and the patient was diagnosed with dapsone-induced methemoglobinemia and hemolytic anemia. For reference, a normal methemoglobin level is less than 0.5%, and the threshold for this diagnosis is 1%. Dapsone was discontinued promptly in favor of atovaquone, and the patient's oxygen saturation and exercise capacity both improved. At his 3-month follow-up, he showed an improved functional status and his hemoglobin had risen to 11. On our last slide, we go over our conclusions. We mostly associate dapsone with G6PD deficiency, but it is also associated with methemoglobinemia and Coombs negative hemolytic anemia in special populations, including patients with solid organ transplant. Our patient had the additional risk factor of kidney disease. It is thought that the dapsone metabolites oxidize heme iron from the ferrous form, Fe2+, to the ferric form, Fe3+, to create this reaction. Metabolites of dapsone are also thought to be toxic to red blood cells. This case highlights some of the challenges faced when caring for patients with multiple comorbidities, including polypharmacy itself. Dapsone-induced methemoglobinemia is an uncommon but important and reversible cause of hypoxemia and anemia. Thank you.
Thank you. Thank you, Danny. What questions are there out there?
Question for you. For the dapsone, what was the dose that was used? I missed that.
Oh, that is a great question that I don't have off the top of my head. I'm sorry.
Sorry. I wonder if the patient was taking the prescribed dosing or more than prescribed.
He was very medically literate, so I would be pretty confident that he was taking the prescribed dosing. He actually was monitoring his own oxygen levels at home, and that's why he came in, not because of specific symptoms. Yeah.
Was methemoglobinemia suspected from the outset?
No, it wasn't. And that was actually something that made this case really interesting while we were in it. Because he had this history of idiopathic pulmonary fibrosis and he had these bilateral lung transplants. And he also had volume overload in the past and CKD. There were a lot of different reasons that he would have hypoxemia and shortness of breath. And so it actually did take a while for us to start going down that path. But then once we did, it was kind of clear. And his oxygen saturations really improved like within 2 days of switching to atovaquone. He was discharged 2 days later.
I think there are methemoglobin levels that require treatment with methylene blue. Am I right?
They are, but the threshold for that is at methemoglobin levels of 20%. And so he was at 10.4%. So he was not treated with methylene blue.
Thank you. And one more question. Was there something about his skin that looked different in terms of color?
Yeah, not that we could notice. To be honest, the only real abnormalities on exam were his lower extremity edema and crackles initially on lung exam.
Thank you, Danny. Rawan?
Alrighty. Good afternoon, everyone. My name is Rowan Emir. I am a second-year resident at the University of Maryland Medical Center. I actually was born in New Orleans, but actually grew up in Saudi Arabia. And outside of medicine, I like to play tennis and scuba dive. So today I'm going to share an interesting case of culture-negative late prosthetic valve endocarditis, unmasking an unusual diagnosis. But before we go into this case, I did want to take everyone on a little bit of a historical journey to see, can anyone recognize those two figures in the photos here? It's a little bit of a tough question. So on your left, you have Dr. Emanuel Libman, and on the right, you have Dr. Benjamin Sachs. And these physicians are the first to coin the term Libman-Sachs endocarditis back in 1942. Now, Libman-Sachs endocarditis is a condition where you have sterile vegetations on the native valves of the heart, and it's commonly associated with malignancies or connective tissue diseases. Here, I'm going to talk about a case of a 46-year-old female that was diagnosed with Libman-Sachs endocarditis of her mechanical mitral valve. And according to our knowledge, this is actually the first case in literature of a mechanical valve involved. Next slide, please. So a 46-year-old female with a history of rheumatic heart disease, status post-aortic and mitral valve replacement, came into the clinic complaining of 3 months of fever and generalized fatigue. Her vitals were stable, her physical exam was unremarkable. Her labs, though, did show elevated CRP and ESR at 130 and 15.9 respectively. The blood cultures that we got showed no growth. She did get a TEE, and if you look at figure 1, you can see that there was a 0.4 millimeter mobile echo density that was found on the mitral valve sewing ring, consistent of vegetations. So, given all these findings, she was started on a 6-week course of IV antibiotics for treatment of prosthetic valve endocarditis, and then was discharged home. Unfortunately, just a week later, she came right back into the hospital with the same complaints all over again. A repeat echo showed persistent vegetations, and repeat blood cultures continued to be negative. So at this point in time, the possibility of non-infective endocarditis was entertained. And an antibody panel was drawn. And as you can see in table 1, she had high titers of anti-cardiolipin, anti-beta-2 glycoprotein, and anti-double-stranded DNA antibodies, consistent with antiphospholipid syndrome. So our patient had Lippmann-Sachs endocarditis of a mechanical mitral valve secondary to undiagnosed antiphospholipid syndrome. She was then started on warfarin and aspirin for anticoagulation, as well as prednisone and rituximab for treatment of her underlying disease. Her antibody titers improved to essentially normal levels, and a repeat echo just a few months later showed resolution of all the vegetations. Next slide, please. So Lippmann-Sachs endocarditis is actually a very rare cause of culture-negative endocarditis. As you can see in figure 2, it affects about 10% of patients with SLE and up to 30% of patients with antiphospholipid syndrome. Now, the exact pathogenesis is still not fully understood, but what we do know is that it only affects native valves. There's only one case reported of a bioprosthetic valve involvement, and ours is the first to report mechanical valve involvement. Now, how do these patients typically present? They usually come in with thromboembolic events or symptoms of the underlying disease. But in our case, the classic symptom of recurrent fetal loss in females of fertile age with antiphospholipid syndrome was actually masked by the patient's primary infertility. Now, how do we diagnose these cases? There's no gold standard, but typically we use TEEs as they have a high sensitivity of up to 93 to 100%. And the important thing is to distinguish this from the most common differential diagnosis, which is infective endocarditis, which we did in our case too. So if we can go back to the main slide, please. So what are the main learning points from this talk today? First, to raise awareness of this underdiagnosed and underreported entity. And second, to highlight how important it is to try to avoid making cognitive errors that are very, very common pitfalls for us as physicians. In hindsight, premature closure occurred several times by assuming that all of her problems were secondary to her valve replacements. Anchoring and confirmation bias prevented us from exploring alternate diagnoses at an earlier time point. Thankfully, the patient is doing extremely well 6 years later. She did want us to share her story with as many people as possible to help educate us as physicians and to help other patients who are in her situation. Thank you so much, and I'm open to any questions or comments at the time.
Thank you, Rowan.
I have a question, Dr. Williams, if it's okay. Very interesting case. Thank you for presenting it. This woman had a mechanical mitral valve.
She did.
And I may have missed the reason why she had that to begin with. But my question is, was she on anticoagulation all along for her mitral valve? And what was she using?
So that's a very good question. She was on warfarin for her mechanical valve, which in theory would have helped the situation. However, the target INR was higher in her situation because she has a mechanical valve with antiphospholipid syndrome. So in her situation, she was technically on warfarin, but subtherapeutic, which is why she formed these vegetations still.
And what would be your target INR?
So according to, there's very limited data, of course, but from what's out there, they prefer a target INR of 3.5 in such situations instead of 2.5 to 3.5, yeah.
Thank you.
Thank you, David. Any other questions out there?
So this is Raja Ayash. Thank you for this presentation. So she was on anticoagulation, but the INR was less than 3?
Yes, correct.
So she was subtherapeutic.
Correct.
But that should be good enough for a hypercoagulable state.
So actually it's actually tricky because there is no data about a mechanical valve and antiphospholipid syndrome with Lippmann-Sachs endocarditis together. This is the first case, so it's very novel and there is no data about it. But when we look through literature, they had recommended an INR of 3.5, not 2.5 to 3.5 in such a situation.
It's interesting, she had infertility, and usually they get recurrent abortion. So that could have been in the clinical point in retrospect.
It is something that definitely I feel may have delayed the diagnosis in her situation, because it is the classic presentation that raises our suspicion as physicians to look for antiphospholipid syndrome.
Thank you.
Thank you, Dr. Ayash, for your questions. And Rowan, thank you for your presentation.
Thank you.
Alex?
Yes, hello. So I'll start by saying thank you very much for having me here. I'm grateful to be here. This has been great. So I grew up in Baltimore, Maryland. I went to medical school in Oregon. I love to run outside as much as possible. I actually ran a marathon with my hospitalist attending last year. So we like to get it in. So I will go ahead and start my presentation now. So this is mucinous adenocarcinoma of a sigmoid vaginoplasty, report of a 1 in 4.5 million event. Let's start with the introduction. So Lynch syndrome is the most common inherited colorectal cancer syndrome and accounts for approximately 3% of newly diagnosed cases of colorectal cancer and 8% of colorectal cancer diagnosed under the age of 50. Lynch syndrome is an autosomal dominant disorder due to a germline mutation in one of the DNA mismatch repair genes and has an incidence of about 1 in 1,000. Meyer-Rodicansky-Kauser-Hauser syndrome, or Mullerian agenesis, is a congenital abnormality associated with the absence of the uterus, vagina, and fallopian tubes, with an incidence of about 1 in 4,500. Several techniques exist to create a functioning vagina for MRKH patients. Among them is the use of intestine, typically the sigmoid colon. We describe a case of combined Lynch syndrome and MRKH syndrome, whose incidence is estimated at 1 in 4.5 million. So a 57-year-old woman originally presented at age 17 with primary amenorrhea. She was diagnosed with Meyer-Rodicansky-Kauser-Hauser syndrome with complete absence of her uterus, vagina, and fallopian tubes. Then a neovagina was created from her sigmoid colon at age 19. At age 29, she developed a renal clear cell carcinoma, and then at age 44, an infiltrating ductal carcinoma of the right breast was identified. Her family history was significant for colon cancer and ovarian cancer in her mother, and colon cancer in her maternal grandmother, who died at age 36 from metastatic disease. Yearly screening with colonoscopy and mammography was done in our patient and revealed no disease. Then at age 54, a 3-centimeter vaginal mass was discovered. The patient was unaware of the mass and reported no pain, hemorrhage, or other symptoms aside from some yellow vaginal discharge. During the course of her follow-up for her neovaginal surgery, the patient actually had 2 vaginal biopsies 15 years apart, both of which were benign. The vaginal mass was biopsied and excised, and the neovagina was subsequently resected. In the next slide, we see excision of the vaginal mass, which showed an invasive, moderately differentiated adenocarcinoma arising in a villus adenoma. The carcinoma extended to the margin of both the excision specimen and additionally excised mucosa segments. So resection of the remainder of the neovagina was performed. In the next slide, we see that after examination of the entire tumor specimen, the carcinoma was further characterized as invasive, moderately differentiated mucinous adenocarcinoma. Now, 1 out of 5 lymph nodes were positive for metastatic adenocarcinoma. In the next slide, we see the remainder of the neovagina showed no additional lesions, and we'll stay on this slide. At age 57, a lymph node excision was performed, and an immunohistochemistry staining revealed absence of MSH2 and MSH6 proteins. Microsatellite testing was performed and expressed a microsatellite instability high phenotype. Now, this is consistent with a diagnosis of Lynch syndrome. In this case, we demonstrate mucinous adenocarcinoma arising in a villus adenoma and involving a neovagina created from a segment of her sigmoid colon in this patient with MRKH. Now, neovaginal carcinoma is extremely rare, such that Shover et al. Summarized 30 cases of neovaginal carcinoma reported worldwide. Of these, 8 adenocarcinomas arising from intestinal grafts, and 17 were squamous cell carcinomas arising from skin graft. No case of current Lynch syndrome and MRKH syndrome was identified in our literature search. Now, this is not surprising given the relative rarity of both syndromes individually. Now, in our next slide, and in conclusion, we report this exceedingly rare case of this Lynch syndrome adenocarcinoma involving the sigmoid colon and construction of the neovagina in a patient with MRKH. And we emphasize that the neovaginal mucosa may undergo neoplastic transformation, and that recognition of this possibility is important in long-term follow-up of the care of these patients affected with MRKH treated by this type of surgical reconstruction. The family history of colon cancer at an early age might have led to genetic testing for Lynch syndrome. Identifications of mutations characteristic of Lynch syndrome could have led to the creation of a neovagina by one of the other techniques that I mentioned earlier, and instead of this isolated sigmoid colon section. And in addition, more aggressive colon cancer screening, including screening of the colon tissue in the vagina, could have been used to possibly spare this patient subsequent metastatic adenocarcinoma. Thank you. That concludes my presentation. I will now take questions.
Thank you, Alex. What questions are there out there? Alex, is renal clear cell cancer one of those recognized to be associated with Lynch?
So that's a really interesting question. So all of the genitourinary, and even in females more so, genitourinary cancers are associated, but usually the cancers are only extending to the pelvis of the kidney itself. So this renal cell carcinoma was actually more involving the capsule and incidental finding on imaging. So I do believe it is associated, but it's not typical for Lynch syndrome.
Thank you. And what kind of screening should this patient have going forward?
Yeah, so now that the vagina, the neoplastic vagina has been excised and removed, she can undergo typical screening as would a Lynch syndrome patient based on both the oncologist and the patient's understanding. But typically Lynch syndrome is at least yearly screening. They usually start at age 23 to 25 nowadays. But I think that for internal medicine, another take-home point can be that identification of the mother having ovarian cancer using Amsterdam criteria and the 3-2-1 rule. So we have to look at successive generations. We have to look at first degree family members, and then 3 people, and then having a solid mass tumor at age under 50. So that identification could have helped this patient realize this is a Lynch syndrome. We need to be careful, and also for those patients' future children. So this is important to us as doctors, not just oncologists in internal medicine.
Thank you, Alex.
Nowadays are screened for Lynch syndrome. And obviously, this lady unfortunately found out later after the fact. But certainly important thing to keep in the back of your mind, Lynch syndrome and screening patients appropriately. Thank you.
Yeah, absolutely. Thank you.
Thank you, Alex. Preston.
Hey everyone, my name is Preston Claiborne. I'm a first year internal medicine resident at University of Maryland Medical Center downtown. Originally from Towson, Maryland, so I'm fairly local. And like Rowan, I like to play tennis in my free time. And I'm interested in hemonc as a career, which kind of coincides with my case right here. So my case focuses on hemophagocytic lymphohistiocytosis, or HLH, which is a rare syndrome of immune overactivation associated with multi-organ failure and unfortunately frequently with death. And it's commonly triggered by a disease that activates the immune system even normally. So such as an infection, a malignancy, a rheumatologic condition, or just genetic predisposition in general. So our case focuses on a 24-year-old male, no significant past medical history, presented 12 days into a course of headache, fever, abdominal pain, decreased urination, as well as shortness of breath. There were really only 2 notable events that occurred before these symptoms began. One was a trip to Northern Virginia where he said he was exposed to an individual that had symptoms consistent with SARS-CoV-2. The other was that he had swam in a freshwater lake in Central Virginia before symptoms began. Otherwise, his medical history was really insignificant, other than him taking an unknown amount of acetaminophen after his headache began initially. So on exam, he was notable to have a fever. He was in sinus tachycardia and was in respiratory distress. Tachypnic, required 6 liters nasal cannula initially, but rapidly progressed so that he had to be intubated. On exam, otherwise it was notable for scleral icterus as well as hepatomegaly extending beyond the midline. Next slide. On laboratory analysis, it was significant for signs of renal failure as well as hepatic failure, as well as thrombocytopenia. He just kind of workup initially focused on what could be causing his liver failure. So because of the him taking acetaminophen in an unknown dose, that level was checked, but negative. The hepatitis viral panel was also negative. And because of his exposure to the freshwater lake, a number of tick-borne illnesses were tested because those can be associated with liver failure, but all negative. Interestingly, throughout this whole time course, he was tested for SARS-CoV-2 with RNA testing 3 times, all negative. In the course of these workup for alternative causes, a workup for HLH was undertaken, and consistent with that, his ferritin and triglycerides were markedly elevated, his fibrinogen was low. And then imaging showed hepatomegaly as well as splenomegaly, both consistent with HLH as well. Next slide. So really to validate the diagnosis of HLH, it's often validated with evidence of hemophagocytes, which are macrophages shown to be engulfing products of the bone marrow. So usually this is detected on bone marrow biopsy, which we found, but even before this, we actually found it on peripheral smear, which is very unusual. And with all of these findings together, using the validated H-score, which gives you the percent chance the patient has HLH, with a number of factors put in there, he had close to 100% chance of this syndrome. Next slide. So with the diagnosis of HLH established, the focus really turned to what was the predisposing factor that led to this. As you can see here, our workup for the 4 main predisposing factors was negative other than a SARS-CoV-2 antibody positivity to the spike protein. And in the setting of his exposure to an individual who likely had COVID, the SARS-CoV-2 antibody positivity, and a lack of really positive workup otherwise, it was deemed that his HLH was most likely secondary to COVID, even with the negative RNA testing beforehand. Next slide. In terms of treatment, it really used an established protocol, the HLH-94 protocol of etoposide and dexamethasone, with the addition of ruxolitinib based off of a case series from the University of Michigan. And with this prolonged course of these medications, he's actually made a great recovery. So he came off of the ventilator after 5 days, came off of dialysis completely, didn't require a bone marrow transplant, which often in these cases is required, and returned to his baseline level of health. We can go back to the first slide. So in conclusion, we present here a case of HLH likely from SARS-CoV-2. I think this kind of highlights that we're still learning a lot about SARS-CoV-2. There are a lot of unique factors about it. It acts in a lot of variable ways. And I think this case also demonstrates that HLH current treatment protocols are helpful relatively in decreasing mortality, although it is still a fatal disease oftentimes. And then for anyone with concern of HLH, this H-score is validated and is very helpful in making that diagnosis, and actually available on MD-Calc, so readily available. Happy to answer any questions.
Thank you, Preston. Was that actually your patient's peripheral smear we saw there?
Yeah, it was. Our hematologist was very keen to notice that when looking at the peripheral smear.
Good for your hematologist. Did anybody in the lab identify that independently, and alert someone ahead of time?
Not that I'm aware. From my understanding, it was just our hematology fellow and the attending went down, took a look at it, and saw it themselves.
Now, could you talk a little bit more about therapy? I mean, why etoposide? Wouldn't it kind of depend upon the underlying cause?
Yeah, so it does, but basically protocols have been developed kind of no matter what the cause. Once HLH is initiated, it's characterized by overactivation of macrophages as well as T cells. So really to dampen that immune response down, one of the key things is to prevent cell division, prevent proliferation of more T cells, more macrophages. So that's why chemotherapy comes on board.
Thank you.
Fascinating with this diagnosis too. And there's got to be some genetic predisposition, perhaps, right? In some patients, what makes them at risk?
Yeah.
Any thoughts on that, Preston?
Yeah, so in this case and in other cases, there is a panel of genetic testing available for patients who are kind of genetically at risk for HLH. We sent that off for this patient, but unfortunately it was negative. So, or fortunately, I should say. So it likely wasn't from a genetic cause. At least none that we know of.
Thank you, Preston. Michael.
Yes, sir. Hi, good afternoon, everyone. My name is Michael Warwick. I'm a second-year resident at Walter Reed. I'm interested in a career in general internal medicine. I grew up in Northern Virginia, and outside of medicine, I enjoy hiking, running, and going to restaurants with my wife. Today, I'm going to be presenting a case of triple negative breast cancer secondary to a BRCA1 mutation that presented as palmar fasciitis and polyarthritis syndrome. So as we go to the first slide, we just little background that palmar fasciitis, as we move to the next slide, palmar fasciitis and polyarthritis syndrome is a rare paraneoplastic disease that typically will present as bilateral tenosynovitis and fasciitis in the palms of the hands that will progress and result in flexion contractures and subcutaneous hardening of the palmar surface, as well as synovitis throughout joints in the bilateral hands and wrists. The clinical syndrome most often is associated with ovarian cancer. However, case reports have linked this to several other neoplastic disorders, and today we'll talk about a case of breast cancer that presented with these symptoms. So as we move to the next slide, we'll be discussing a 47-year-old female without any significant past medical history who came to her primary care doctor with the complaint of several months of pain, swelling, paresthesias in her bilateral hands. Tinel sign was positive on the exam, and so an EMG was obtained that confirmed carpal tunnel syndrome, and she was treated as such with conservative measures for several months before eventually going operative carpal tunnel release. She had no improvement in her symptoms despite a couple more months of occupational therapy, and she was eventually referred to rheumatology. The rheumatologist sent serologic workup, and with this MRI that was obtained, confirmed inflammation in the carpal tunnel, but also noticed tenosynovitis and fasciitis throughout the bilateral hands and synovitis in multiple interphalangeal joints. When the serologic panel came back with only a mildly elevated ESR and a low titer of ANA, a brief course of oral prednisone was trialed for therapy. However, the patient's symptoms remained refractory, and this raised some concern for an underlying paraneoplastic syndrome, specifically palmar fasciitis and polyarthritis syndrome. So as we move to the next slide, you'll see that they did obtain a CT abdomen pelvis, a transvaginal ultrasound, and tumor markers, initially looking for evidence of ovarian cancer, which is strongly linked to the disorder. After a CT chest and mammogram were ordered to complete the malignancy workup, a large left axillary lymph node was identified. This was biopsied and found consistent with a poorly differentiated carcinoma. Staining with CK7 and GATA3 were positive on immunohistochemical stains, which suggested a breast primary. After it was found that the cancer was triple negative, a genetic panel was also sent for the patient, and she was identified to have a pathogenic variant of the BRCA1 gene. So she initiated neoadjuvant chemotherapy for the treatment of this triple negative breast cancer. She did have some improvement in her palmar fasciitis and polyarthritis symptoms, although the contractures in the hand are often irreversible. But as we move to the last slide here, this case just highlights the importance of keeping a neoplastic disorder high on your differential and keeping an index of suspicion for this, as identification of such may allow for early diagnosis and more timely management of the underlying cancer. Specifically with palmar fasciitis and polyarthritis syndrome, this highlights that other disorders outside of ovarian cancer are linked to the disease and should be kept on your differential. It also illustrates that a diagnostic feature that may help in distinguishing these cases from other etiologies of an inflammatory arthritis is the refractory nature to glucocorticoid therapy. And I think finally, what most important about this case is the importance of the fundamentals of internal medicine, the history and physical exam, as it was identified later with a more complete history that the patient's grandmother had ovarian cancer, her mother had breast cancer in her 50s, and that was not elucidated on the initial exam. And then that lymph node was not identified on any physical exams leading up to it being identified on radiographic images. So it just highlights the importance of a good physical and history. So with that, I'll take any questions.
Thank you, Michael. Do you think this Tunnel's, positive Tunnel's bilateral carpal tunnel was that incidental, or why might that have occurred?
I believe she truly had carpal tunnel syndrome because EMG studies were obtained that confirmed that were consistent with the diagnosis. The MRI imaging did show inflammation not only in the palmar fascia and multiple joints, but also in the carpal tunnel with inflammation in the carpal bones. So I think it was secondary. The median nerve was compressed due to the inflammation from the palmar fasciitis.
Does the Palmer process just look like a Dupuytren's?
It can look very similar to Dupuytren's contractures. There's more synovitis in the joints and then nodularity along the fascia of the palms, but that's Dupuytren's contractures are definitely on the differential when you have that type of presentation.
Thank you.
Was the paraneoplastic, I guess to prove that, I guess maybe she would have got better when she got treated, or if there was a paraneoplastic panel that was sent, just to make that connection.
The panel that was sent was largely all the rheumatologic things we think about, like rheumatoid factor, ANA, anti-double-stranded DNA, Smith, ribonucleoprotein, those things. Once it was suggested that there was a paraneoplastic disorder causing the symptoms, it was from there focused on age-appropriate cancer screening and then a CT chest, abdomen, pelvis to look for a primary.
Thank you. Yeah.
Thank you, Mike. Sanjivani.
Hello. Good afternoon, everyone. I'm Sanjeevni, and I'm a second-year medicine resident at MedStar Health. I'm interested in pursuing my career as a nephrologist. And outside of medicine, I love music and I love singing. So I'd like to start. I would like to first thank Dr. Berliner, who's a nephrologist and who's my primary mentor in this case. First, talking about oxalic acid. Can you please take me to the next slide? Thank you. So oxalic acid is an organic acid, which is found in food like spinach, nuts, and tea. And it is excreted by the kidneys, and when in excess can lead to renal tubular deposition and acute kidney injury. And I'm going to talk about a case where this patient had a lot of iced tea and hence caused oxalate nephropathy and acute kidney injury. Iced tea is something which we are very familiar with, but we do not anticipate that it can cause kidney dysfunction. So he was a 59-year-old gentleman who presented to the emergency with lower extremity weakness, dry mouth and nausea for 1 month, and decreased urine output for about a week. His past history included coronary artery disease, type 2 diabetes mellitus, stage 3 CKD, chronic kidney disease, and he had a history of laparoscopic gastric sleeve gastrectomy in the past. Examination revealed that he had urinary obstruction, so we had to place Foley catheter, but otherwise was unremarkable. His labs were significant for hyperkalemia, had elevated creatinine of 7.8, while his baseline was 1.2. Urinalysis showed microscopic hematuria and proteinuria. And we also did some rheumatological workup for like vasculitis, glomerulonephritis workup, and it showed low complement C3 levels, but otherwise was negative. We did imaging, renal ultrasound studies that did not show any abnormalities, no hydronephrosis. And so our differentials were for AKI was bladder outlet obstruction, but despite Foley catheter, he did not improve. Other differentials we considered were post-infectious glomerulonephritis, considering the low C3. And others were interstitial nephritis because he recently took amoxicillin for his dental pain and infection that was about 3 weeks prior to presentation. But despite conservative management, his AKI did not improve, so we had to take biopsy samples from his kidney and we had to start him on hemodialysis. So after stabilization, we discharged him on outpatient dialysis schedule awaiting biopsy results. And when the biopsy results were back, we were very surprised because it showed intratubular oxalate concretions and acute tubular necrosis that's consistent with oxalate nephropathy. So we called him to give him his biopsy results and then asked him like if anything, any particular or odd or anything different diet that he was taking that's responsible. And he told us that he was taking a lot of iced tea, maybe about like 2 liters of iced tea every day because before coming to the hospital, he had this dental pain infection and he couldn't really eat. And so to remain hydrated, he was taking a lot of iced tea. So we told him that that might be the reason for his AKI, his kidney damage, and we advised him to stop. And gradually, he was able to be weaned off dialysis. If you can take me to the next slide, please. So these are the biopsy pictures and generally shows diabetic nephropathy changes with glomerular like nodules in the mesangium, thickened capillary loops, arterial hyalinosis. And in figure 5, that's the biggest picture there, we can see calcium oxalate crystals inside his tubules marked by the green arrows causing tubular obstruction. And in figure 4, you can see tubular atrophy that's consistent with ATN and oxalate nephropathy. Next slide, please. So discussing about increased oxalic acid hyperoxaluria in the urine can be primary as well as secondary. Primary due to enzymatic defects and secondary due to increased intake like diet rich in oxalate, spinach, tea, nuts, chocolate, vitamin C. It can also be caused due to fat malabsorption like in pancreatitis, gastric, bypass surgeries like Roux-en-Y gastrectomies. And there's some evidence showing that oxalobacter bacteria colonization, if it is decreased, can also lead to hyperoxaluria. So to conclude, we should take a thorough dietary history to find out the causes of AKI, and we should be mindful that though iced tea is very popular, we should be mindful that it can cause serious kidney dysfunction due to oxalate nephropathy. And if you can take us to the first slide. That's the references, and yeah, thank you. And I'm open to any questions.
Thank you, Sanjivani. You know, of course, in the summer, particularly all of us, many of us will drink a fair amount of tea. And I'm just wondering, could there have been a cofactor And for example, could there be occult malabsorption like celiac disease? We know this hyperoxaluria can be an issue when there's malabsorption present.
So are you giving, are you like referencing to the sleeve gastrectomy that he had in the past, or?
Well, for example, I've seen this in patients with Crohn's disease
Mhm.
or some of the older bypass surgeries that were done. Basically, and I'm sure you're all on top of the mechanism and so forth, but the calcium gets pulled in by the fatty acid, and now the oxalate is free to be absorbed in the colon and excreted in the urine. So I'm just wondering, in addition to the T, if there might have been, and we know celiac can be very occult, if there might have been other issues, for example, malabsorption.
We tried to look into that. He did not really have any symptoms, although you said that it can be occult. He didn't have any GI symptoms prior. And with the sleeve gastrectomy that he had in the past, we looked at the references, and we found that it's not really associated with malabsorption because it decreases just the volume of the stomach, while in cases of bypass surgeries, it has like a small stomach where that is directly linked to the jejunum, and there's bypassing of the duodenum and ileum, other parts of the small intestine, which is responsible for fat absorption. So I think in his case, it could have been, but is less likely that he had a malabsorption as to one of the causes for his oxaluria.
Thank you. What other questions are there out there?
I would imagine recovery is not good for this condition. Would that be correct to?
Yeah, some in the literature, we found that one case had ended up needing dialysis, like being dependent on dialysis, but this patient was lucky enough, we could bring him off dialysis about like 8 weeks later on. So
Is that the typical norm that patients will recover once they?
There was cases which did not even need dialysis, but he needed, so it's like he's in between those which is with good prognosis, whereas with, and also bad prognosis.
Thank you, Sanjivani.
Thank you.
Well, so greatly appreciate all of you and all that you and your patients have taught us today. And I invite you all to stick around for a wonderful presentation in this room coming up at 1:30. Dr. Cruz will be talking about issues of health equity. So please grab whatever you need in terms of food or drink, but do come back to this very room at 1:30 for Dr. Cruz's presentation. And then at 2:15, we'll be announcing the award winners in several categories. So do come back to this room at 2:15. For those judges on board, please join me in the staff room. And let's caucus and undertake this very difficult process. So I will be leaving, and thank you all presenters once again, and I look forward to meeting the judges in the staff room. So go on that link.
All right, welcome back, everybody. Dr. Galati, are you on?
Ted, how are you? Ted, can you hear me?
Yep, whenever you're ready.
Perfect. Great. Welcome, everybody. It's been a great morning. We've really had the privilege of hearing many different cases and research vignettes from many of our residents. So thank you, everybody, for the time this morning. We're going to go ahead and move into the keynote presentation. The keynote is pre-recorded, but Dr. Deirdre Cruz, who is delivering the keynote, will be back at about 3 o'clock in person. So if you have any questions for her as you're listening to her keynote, please type them into the chat. It's my great pleasure to introduce Dr. Deirdre Cruz, who is a professor of medicine in the Division of Nephrology, the Associate Director of Research Development at the Johns Hopkins Center for Health Equity. She's also the Director of the Doctoral Diversity Program at Johns Hopkins School of Medicine. And Dr. Cruz is going to talk to us today about her path to a career in health equity.
Good afternoon, and congratulations to those of you who are presenting your work today. I'm Deirdre Cruz, and I'm really excited to be with you all today and to share with you a bit about my path to a career in health equity. So I really have just one objective, and that is to share today. I'm going to try to share a bit about my journey to the work that I do today. I'll share some of the work that my colleagues and I have conducted, and then I'll also share some insights on what I see as the path forward towards helping us to achieve health equity. So a little bit about kind of where I come from. So I'm originally from a fairly small manufacturing town in Southern Virginia called Danville, and I really spent all my life there prior to going off to college. I come from a really wonderful family, including my husband and daughter that are there in the middle with me, and really a family that has been marked, I think, by a lot of kind of public service, both in the professional work and the kind of community work that my parents especially have been engaged in, and that really helped to shape me as a person and also to influence the work that I would later do as a physician. I am the eldest of the grandkids on both my father's side of the family and my mother's side of the family, and while you may think that would make me the favorite, certainly my brother and many of my cousins give me a run for that title with my grandmother, who is now 91. We have a very large family, especially on my father's side, where he has 90 first and second cousins, or 90 first or second cousins, I should say. And that makes for a lot of fun, and certainly it can make for a lot of great accomplishments that we get to see within our family, including a couple of years ago, two of my cousins became the first brothers to be drafted in the first round in the National Football League. And actually in that very same year, a group of my cousins posted a respectable performance on Family Feud. And so we really do have a lot of fun in our family. As I think about pivotal people and experiences, when I think about my especially my early journey towards becoming a physician scientist, as I mentioned, I come from this large family. In addition to some of the great successes and fun that we've had, our family, like many families, particularly many African American families, has had experiences with kidney disease. And so including here on the bottom left-hand side here, my Aunt Charlotte, who was a sociologist, an academic sociologist, and did suffer from both type 1 diabetes and end-stage kidney disease. She is one of several of my relatives who was impacted by kidney disease, including kidney failure. And while at the time, especially as a very young person, I did not already have a plan of becoming a nephrologist, which I am today, But in retrospect, I think these experiences with family members certainly did shape my path that was to come. My earliest memory, if someone had asked me what I would be or what I wanted to be when I grew up, my earliest memory was that I would have responded that I wanted to be a scientist. And how that manifests as a 10-year-old or so was that I spent a lot of time in our yard, kind of looking for animals that may have sort of met their demise out in the wild and trying to understand what may have happened to them. I had a great fascination with frogs that I would find in the yard. And I was fortunate later as a kind of a middle schooler to get involved in a medical explorers club that was led by a local pathologist in our town, who had sort of put together this group to expose kids to opportunities in medicine. And really, because of such a great experience with him, and finding that he was just this generous person with his time and his expertise, my earliest sort of memory of what specialty I wanted to go into in medicine was actually that I wanted to become a pathologist. And in fact, I entered medical school planning to become a pathologist. As a medical student at St. Louis University, I did then get to have my first experiences in research, including completing a visiting research elective at Johns Hopkins, where I had the opportunity to work with Dr. David Levine and Miss Lee Bone, who are featured there in the middle, on a project called Project Sugar, which was addressing disparities in diabetes with a particular focus on African Americans living in Baltimore. And so that was really one of my earliest experiences with respect to health equity research. And it was a wonderful experience in that they were conducting community engaged research addressing health equity. And it really opened my eyes to some of the possibilities in that in that field. Another really pivotal experience for me was that given the focus of my medical school on service of the underserved, we had the opportunity, many of the students there, to actually go on international trips or international electives to provide medical service in under-resourced countries around the world. And I did get to travel and spend about 5 weeks in what was then called Swaziland, or Eswatini as it's called now, which is a very small landlocked country in southern Africa. It's landlocked inside of South Africa. And it was actually there that I really got the first glimpse into what it means to have your health be socially determined, meaning that those social factors really existing outside of an individual's own characteristics or their genetic background, all of those things, that to have your actual health outcomes shaped by these sort of social forces or societal forces. As an example, in our time, myself and the other students, in our time in Swaziland, we were treating a lot of people who had HIV infection and consequences of that. At the time, Swaziland had the third highest rate of HIV/AIDS in the world. And that disease had really ravaged the workforce there. So many young people were affected. It had impacted the number of teachers and police officers and so forth that were working and were able to work there in Swaziland. And in our clinic, what we would find is that we would often see patients who would come in to be seen, and we might diagnose them with one of the sort of opportunistic infections that was kind of related to the fact that they had HIV infections, such as tuberculosis. And there were multiple occasions where we might diagnose a woman with TB, for example, and in telling that woman, hey, you're very sick, you really need to be admitted to the hospital and be treated, time and time again, what we would find is those women would say, okay, well, I'll need to travel back home and asked my husband for permission to be admitted to the hospital. And what we would often find is that those women never, after leaving to go home and ask for permission to be admitted, they actually never would make it back to the hospital. And we can only presume that those women passed away. And that situation was because to be admitted to the hospital there in Swaziland, it did require being able to pay the bill that would sort of come after being admitted. And that was such a burden on families that there was sort of a lot of sort of discussion and consideration around whether being admitted would be warranted, and such that so many people avoided seeking healthcare because of the cost that was associated with it. And so that was really, for me, a very early glimpse into these challenges surrounding these social drivers of health. And then after medical school, I matriculated as a intern and then later resident in the Osler program at Johns Hopkins. And it was there that I, in taking some of the lessons that I learned as a medical student, then began to think about the clinical experiences that I had, the clinical encounters I had, and begin to sort of develop research questions surrounding them. And I was fortunate to have some very gracious and patient mentors who worked with me and helped me to shape some of the questions that came to mind and helped me to sort of put them into terms that could actually be testable. And including on the top there, Dr. Bernard Jarr and Dr. Neil Poe, who worked with me on really what was my very first research project, which was one that grew out of my seeing that there were many people who we saw in the emergency department during my residency who kind of landed in the ER and were told that they had kidney failure and would require initiation of dialysis during that hospitalization. And in many cases, these were people who had no prior knowledge of having chronic kidney disease. They had never seen a nephrologist. And I began to become curious about what happened to those people who were initiated on dialysis in such an urgent kind of way, in such an urgent presentation, compared to those who may have been followed by a nephrologist, for example, or closely followed by a primary care physician prior to starting dialysis, and may have been able to start dialysis as an outpatient. And so my very first research project that I was the first author on was focused on that question. It took me 7 tries to get that paper published, but ultimately it was, and it taught me a lot of perseverance around this space of research. As I transitioned on to starting fellowship in nephrology at Johns Hopkins, and then later onto faculty, I was really fortunate to be mentored by Dr. Ebony Boulware and Dr. Pete Miller, that are whose pictures are there on the bottom right-hand side. And it was really around this time that I began, through their mentorship, to understand that a person could actually be both a physician and a scientist, and that I could combine this this early desire that I had had around becoming a scientist with now being a physician, and that could really help me to shape a career. And so, as I mentioned, my journey really has been towards one of focusing on health equity and research, in particular, to help us move towards health equity. And so I think important to share one definition of health equity. And so it basically means that everyone has a fair and just opportunity to be healthier. And this certainly requires the removal of obstacles to health, such as poverty, discrimination, and their consequences, including the removal of things like powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and also removal of obstacles to healthcare. What we see in the United States is that health inequities are very costly. It's been estimated that $50 billion a year are spent as a result or as a consequence of health inequities. And it's been noted that 30% of medical expenses for racial and ethnic minorities in the United States are due to excess costs that stem from health inequities. And I think a key sort of issue that underlies what we see, particularly when it's with respect to health inequities, is that the United States actually spends less on social services than other countries, and it's the only country that spends more on healthcare than it does on social services as an overall percentage of our gross domestic product. And so this certainly may be one of the reasons that we see some of the health outcomes and particularly some of the health inequities that we see in this country. And so as a nephrologist, certainly my focus is on kidney disease, and we see that inequities in kidney disease are tremendously profound. We know that African Americans, for example, comprise 13% of the US population, but they comprise a third of those individuals who have kidney failure. Hispanic and Native Americans are twice as likely as white individuals to develop kidney failure. And people who have low incomes are also twice as likely as those who have higher incomes to develop kidney failure. And when we think about the optimal treatment for kidney failure, that being receiving a kidney from a living donor, what we see is that African Americans, Hispanic, and Asian Americans are less likely to receive this type of kidney transplant than are white individuals. And so a number of investigators have put forward these different models, these conceptual models, to help us think about what connects having social disadvantage to having a greater risk of developing chronic kidney disease. And so on the far right-hand side, what you'll see are issues kind of surrounding uninsurance or underinsurance status and how that can impact access to healthcare and also both the diagnosis and the management of a number of different clinical risk factors for going on and developing chronic kidney disease, including diabetes and hypertension, as well as cardiovascular disease. In the middle, what you'll see is that discrimination and those factors that stem from it are also thought to be drivers of what we see in terms of disparities in development of chronic kidney disease and its progression. And while this is an understudied area specifically in kidney disease, what we note from other work in other health conditions like cardiovascular disease is that discrimination or the experience of discrimination can actually lead to chronic stress and can lead to hormonal or neurohormonal specifically activation. And there can be downstream impacts on that, both on the individual's behaviors and but also physical downstream impacts that again can lead to an increase in some of these clinical risk factors that we see for chronic kidney disease. And then on the far left-hand side are those issues that stem from residential segregation. And so from here, what we really are thinking about are those issues that stem from this really long-standing practice in many cities, in particular around the United States, where there's been the process of redlining, for example, which is a approach that a number of cities began taking around the turn of the 20th century, cities including Baltimore, where both Black individuals and religious minorities, including Jewish individuals, were restricted in terms of the communities in which they could get loans to purchase homes or get loans to start businesses. And this has led to there being this segregation of many of those groups in cities like Baltimore, but also really in many cities across the country. And what happens in those settings is that what we see is in those racially segregated, residentially segregated communities, often there are issues surrounding poor housing, increased environmental toxin exposure, including air pollution. There are also there's poor quality education being offered often in those school systems, and all of those can actually really influence people's risk of developing chronic kidney disease ultimately, as well as a whole host of other health conditions. And so in our time together, what I'd like to do is highlight some of the work that my colleagues and I have done really addressing these three areas. I'll sort of briefly touch on some of that work. So when it comes to perceived discrimination and kidney function, this is really an understudied area. And in a Baltimore-based study, my colleagues and I looked at self-reported perceived racial and perceived gender discrimination across 5 distinct situations. And so those situations included in the school setting, when trying to get a job, at work for those already employed, at home, and also when seeking medical care. And we also examined a general measure of the experience of discrimination that's been developed and validated. And what we found, just to give you kind of the quick summary here, was that among white women, we found that a high level of experience of discrimination was associated with a lower level of baseline kidney function in this study. And we found that among African American women, both perceived racial and gender discrimination were linked to a lower level of follow-up kidney function in this study. One of the really important pieces of my career, or really an important, I think, approach in my career, has been that of collaborating with colleagues from different disciplines. And it's really enriched the work that I've been able to do, and also has helped me to learn and have fun as well while doing this work. And so one really wonderful collaboration has been with Dr. Sarah Zanton, who is a professor of nursing at Johns Hopkins. And she, along with some of her colleagues in nursing, developed a program called CAPABLE. And CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. And I highlight this work here because it really gets at this issue of housing and what poor housing can do, or the impact that it can have on individuals. And so in Dr. Zanton's work, they developed this program that is for low-income older adults who, in many cases, have home environmental risks, so meaning inside of their home, there are, because of the structure of it, there are places where these older adults may be at risk for falling or injuring themselves. And also because of the way that their homes are structured, they can limit these older adults' ability to really be functional in their homes. And so this program is focused on the individual participants' strengths and deficits, and also their goals surrounding things like their activities of daily living or their instrumental activities of daily living. So including things like being able to dress themselves, cook a meal for themselves, etc. And CAPABLE is a 5-month home-based intervention that involves a nurse, an occupational therapist, and a handyman or handy worker. And what the nurse and the occupational therapist do is they do an assessment of the participant, and they work with them to set goals around how they would like to function. And then the occupational therapist provides a work order to the handy worker, who makes up to $1,300 worth of repairs to support that person's functioning. What has been found is that this approach, in addition to being able to improve functioning of these individuals who participated, it's actually been estimated that it leads to cost savings in terms of Medicare cost for those individuals who are participants of such a program. And so this is the publication a couple years ago that really highlighted that this was effective at improving disability in this population, again, this low-income older adult population. So I'm specifically sharing this because through work with Dr. Zanton, we actually then developed a version of CAPABLE that was focused on people with end-stage renal disease or end-stage kidney disease. And here we called it Sociable, which stands for Seniors Optimizing Community Integration, Advancing Better Living with ESRD. And we started off by conducting some focus groups of our target group that we wanted to focus on, those being older adults treated with hemodialysis who also had low levels of socioeconomic status. And through those focus groups, we identified a number of different themes in terms of considerations and concerns that these individuals had, including feelings of fatigue, lack of social support that they felt like they were receiving from family and friends, and then also a desire to live independently if able to. And we pilot tested this intervention, and we did note these improvements in physical and social functioning. and concluded that these home-based interventions like this are feasible even in this population of people treated with dialysis, and could lead to favorable outcomes in this vulnerable population. Again, people largely with low incomes who are treated with dialysis. And so this issue of housing insecurity is one that has just in general not received a lot of attention, or hasn't been studied very much in the kidney disease setting. And through work with Dr. Tessa Novick, who was a resident at Johns Hopkins in internal medicine some years ago, and then became a fellow in our program at Hopkins as well. We have done some work looking at housing insecurity and how that can set a person up to have risk of developing kidney disease. And we used, again, data from the same study that I mentioned earlier that's based in Baltimore. It's called the Handle Study, or the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study. And we looked at a question that was captured in the Handle study, and that being, are you able to afford a home suitable for you and your family? And we found through examining that question that a third of the participants in this Baltimore-based study did have housing insecurity. And then after about 3.5 years of follow-up, we found that the overall population that we examined, that around 16% of them developed rapid declines in their level of kidney function. Their glomerular filtration rate was rapidly declining. 5% of them newly developed a GFR that was less than 60, and 7% of them newly developed albuminuria during that time period. And we found that housing insecurity was statistically significantly associated with developing albuminuria, including after we adjusted for a number of different factors, but we didn't find that relationship with respect to the other outcomes that we examined. When it comes to dialysis patients and thinking about this issue of housing insecurity and really the most severe form being homelessness, this is an area that we have tried to call attention to, including through this kind of perspective piece, where we called for consideration of providing permanent supportive housing to people who have end-stage renal disease, to try to offset some of the acute care costs, like emergency room visits that these individuals may have, and the hospitalizations, given that it is just unimaginable to think about trying to manage a need for coming in, for example, 3 times a week for hemodialysis for a person who is homeless, and in other health conditions. Permanent supportive housing has been quite effective, and so this was something that we've called for. And I think that work really highlighted something that I have learned more and more about through my career, and something that if I had to do it over again, and certainly my recommendation to you all would be to try to get more informed about, and if you have an interest, get engaged in this issue of health and public policy, in that these are really important approaches to actually helping us to achieve health equity. I was very fortunate early in my faculty career to be selected as a National Academy of Medicine fellow, and through that was able to get training in health policy and sort of how health policies are made and formed, and how they then can be really ways to help us achieve global outcomes that we want to see with respect to the health of populations. And through that was able to participate in a number of different committees and other activities of the National Academy of Medicine. So turning now to this topic of nutrition, which again is one that falls in many cases under this umbrella of the impact that residential segregation can have on socially disadvantaged individuals who have chronic kidney disease. Certainly when we think about chronic kidney disease, nutrition is a cornerstone of the work that those of us taking care of patients with CKD are doing. in that we certainly advise patients around certain ways that we would recommend that they eat in order to prevent their kidney disease from getting worse or prevent them from having complications of it. And so whenever we make recommendations about food and nutrition, it certainly assumes in some ways that the person we're speaking to, the patient we're speaking to, has availability in their community to kind of get to a grocery store. It assumes they have transportation. It assumes that on balance that there's a greater presence, if you will, of healthy food options surrounding them than there are fast food restaurants and places where unhealthy foods might be being sold. Exercise and nutrition go hand in hand. And so whenever we are making recommendations around nutrition, we often will tie in a piece around exercise. And then also nutritional counseling in the setting of chronic kidney disease certainly does assume often that a person has individual purchasing power. It assumes they've got enough money to buy these foods that we are recommending. And so some of the challenges, though, that we face in this thinking about this for kidney disease or other health conditions is that healthy food availability varies in communities. And this is work by Dr. Manuel Franco, who is a faculty member at the Johns Hopkins School of Public Health, who using data from the Johns Hopkins Center for a Livable Future, looked at the availability of healthy foods. So here looking at things like fruits and vegetables and whole grains and low-fat dairy foods by location. And what the location, these locations were sort of defined by was the racial composition of the neighborhoods. And this is, so the box here indicates Baltimore City, and then the surrounding areas outside of the box, that's Baltimore County. And those communities shaded in gray are those that are where the residents are predominantly white. And in those communities shaded in white, the residents are predominantly Black. And the size of the green circle indicates the amount of healthy food availability. So the larger the size, the greater the amount of healthy food there in that community. And what they found was that, and you may note here that those green circles mostly overlie those gray shaded areas. And indeed, they found that those communities where most of the residents were white individuals, and those communities where there were higher levels of average income, household income in those communities, there was a greater amount of healthy food that was noted there. We were interested in really the individual experiences that low-income African Americans in Baltimore might have around this idea of preventing themselves from developing kidney disease through dietary changes. And we in particular sought the viewpoints of African Americans here who had a first-degree family member who had kidney failure, interested again in what their thoughts were on what could be done to help them to not have the same experience as their family member. And this was a focus group study, a qualitative research study. And what one of the participants noted was, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. And so they noted that this availability of healthy foods was a challenge, and also that unhealthy foods are more convenient to prepare or to access. And finally, they noted that these sort of dietary practices that they had were a lifelong habit that they thought would be difficult to break. Another great challenge that can have an impact on health outcomes and certainly health equity is this issue of food insecurity. And so that's defined as the limited or uncertain ability to acquire nutritionally adequate and safe foods in socially acceptable ways. And what we see is that both non-Hispanic, Black, and Hispanic individuals in the United States have a greater burden of food insecurity. And that burden tends to spike really for all groups during times of economic downturn. And certainly we saw that during the Great Recession, and we're seeing that now during the COVID-19 pandemic. This is some data from Feeding America showing the states with the 10 highest rates of projected food insecurity for 2020. And what they note is that states, for example, like Texas, they were projected to have about 18.5% of the households there experiencing food insecurity in 2020. We have looked at this relationship between food insecurity and the development of end-stage kidney disease. We did this analysis among people already with chronic kidney disease in the United States, and found that for those who did have food insecurity, they were more likely to progress to develop kidney failure. When we went on to account or adjust for some of the factors that relate to either food insecurity or risk of developing chronic kidney disease, we were encouraged to find that when we included nutritional factors in our analysis, that we were able to explain some of that relationship that we saw. That gave us hope that if we can support through nutritional interventions, for example, people who are experiencing food insecurity, that we actually may be able to reduce their chances of developing kidney failure. And so we are currently conducting a clinical trial that's really trying to tackle some of these challenges that I highlighted. The study is called 5+ Nuts and Beans for Kidneys, and it builds upon a successful pilot study of this type of intervention. But here we're focused on conducting a 12-month community-based dietary intervention study for 150 low-income African-American participants, many of them living in food deserts, many of them with food insecurity, and all of them have hypertension, plus they have albuminuria. And we're testing whether delivery of advice around following a DASH-like diet, which hopefully all of you have heard of and are familiar with, the dietary approaches to stop hypertension dietary pattern. Plus, we're providing them with $30 per week worth of fruits, vegetables, nuts, and beans, which are potassium-rich foods. And we're partnering with a local grocer to provide these foods. And the outcome that we're focused on is reduction in loss of albumin in the urine, or urinary albumin excretion, and also improvements in blood pressure. Ours is a community-based participatory research study where we have numerous partners, including our grocer partner, ShopRite, that's featured there. In a related project, we have used a kind of I think a novel research method called photo voice, wherein this project is led by Dr. Anika Hines. But the participants here are trained in using a camera to take pictures of their food environment. And in this case, what we have done is we've recruited people who were almost eligible to become a part of our main study, 5+ Nuts and Beans for Kidneys, but for one reason or another were not found to be ultimately eligible. And we have included them in this photo voice project. And so here are some of the photos that have been taken through Photo Voice, including this one that highlighted a vacant building and noted that discriminatory practices against Black individuals here in Baltimore don't allow them to buy lots and buildings, and that in this participant's viewpoint contributed to some of the issues surrounding the food environment as well. And then this participant who, in Photo Voice, who started some years ago, started his own garden based upon something that he had seen at a store. And he noted that he and others in his community have concerns around crime and safety that sort of makes them not feel as comfortable really navigating their neighborhood to seek out food purchases. And this was an approach that he took on that has been helpful for him. Really to have this home garden. We had worked with an artist recently to develop a kind of a representation of many of the themes that emerged from the Photo Voice project that are highlighted here. A number of them were really themes surrounding social justice, and these participants really saw this issue of the availability of food in their communities to be one of justice and worth addressing, both towards in achieving health equity, but also greater social justice in general. And so certainly this past year has been one where health equity and health inequity has been highlighted. And what we've seen in terms of the COVID-19 pandemic and also these high-profile acts of racism have had some disproportionate consequences on communities of color in particular, including those noted here, such as disproportionate grief due to loss of individuals who died from COVID-19, on to really a heightened fear of institutions, fear of violence and harassment as well, such as what we've seen for Asian Americans, I think most recently highlighted by instances that we've seen covered in the news. And as we move towards trying to achieve equity, an important approach that my colleague Dr. Lisa Cooper and I have highlighted here in this article was that it's going to require that we really work hard to enhance trustworthiness in both healthcare and in research. A couple of avenues towards doing that include enhancing our relationship-centered care that we provide to patients. It also, and this is something that I highlighted a bit of, it also really requires that we as clinicians enhance our structural competency. And that means that we increase our awareness around many of these health inequities and societal injustices, and really re-articulate the way that we think about, why an individual person, for example, may be not adherent with the therapy or a recommendation that we make, into terms that acknowledge that that they may have structural barriers to achieving that level of adherence that we would certainly want them to have. And really together through these approaches, we will establish greater trustworthiness with patients, and this will help us to move our agenda forward with respect to health equity. And so to summarize here, health equity means that everyone has a fair and just opportunity to be healthier. Inequities in chronic kidney disease are profound. And in my view, we will achieve kidney health equity and health equity more broadly through addressing some of the needs that actually may exist outside of healthcare, including in the community setting or in the home setting, through engaging with multiple stakeholders, including patients, and also ensuring that structural competence is there in both our care delivery and also in the research that we conduct. And so I'll end there, and I would invite you all to please drop questions for me in the chat, and I look forward to responding to them. Thank you.
Good afternoon, everybody. I'm going to start by thanking Dr. Deirdre Cruz for presenting such an insightful keynote address. It was really very, very interesting and really does highlight a lot of the work that we need to do as a medical community. Good afternoon to our Maryland ACP programs, residents, judges, and faculty. I want to say how pleased we all are to have all of our programs so actively involved with this meeting. And not just this meeting, throughout the year, we've had many, many activities. Some of them are regular, usual activities, and we've added many new activities as well. This year has been extremely challenging for us, but I think the Maryland chapter has really risen to the challenge of making sure that we're fully committed to making sure we are continuing all of our activities. I want to take this opportunity to really thank some people and thank all of you for your support as well. And to thank Ted Cumston, who is our Director of AV, who has put so much effort into making this meeting so fantastic, and also all the other virtual meetings that have occurred throughout the year. I want to thank the advisors for this specific virtual residence meeting, Dr. Janaki Deepak, Dr. Dobin Chow, Dr. Richard Williams, Dr. Sapna Kul, Dr. Dave Weissman, Dr. Colleen Christmas, Dr. Dave Zolette, and Dr. Steve Sisson. And of course, I would be absolutely remiss if I did not thank Mary Ellen Woodward for making all of this happen and keeping us absolutely on track, as she always does. We could not do this without the support of this committee and the support of all of you, so thank you. I want to take a moment to acknowledge the 50, actually a little more than 50 judges who took time from their busy schedules to support this meeting. support our residents and also provide educational tips as we were listening into the research and clinical vignettes this morning. Thank you to all of the presenters for taking time to find these really interesting cases, putting them together, and then taking time to present them to this group today. Thank you to all of our programs for making this meeting happen every year for us. Thank you to all of our CRAB members who are such wonderful supporters of all of our activities. And now this has become in not only this new virtual format, but as well. Special thanks to our CRAB co-chairs this year. We will be sending each of you a plaque in the coming weeks to thank you for your activities on the behalf of the Maryland chapter. I want to take a moment to acknowledge each of these CRAB co-chairs. Dr. Summer El-Radi from Anne Arundel Medical Center, Dr. Maria Khan from Kaiser Permanente, Dr. Raj Dengol from MedStar, Dr. Joan Lee from Sinai, and Dr. Safwan Mohammed from UMC Midtown. At this time, we're going to present the first award of the afternoon, which is the C. Lockhart Connolly Award to Dr. Bernard Jar. Dr. Dobin Chow, who is our awards chair, will be introducing this award, followed by a few words of appreciation from Dr. Sam Kunt, a current nephrology fellow and a wonderful member of our ACP Council.
Dr. Galati, thank you very much. It is my privilege and honor to present the 2021 C. Lockhart Conley Award. Each year, the American College of Physicians Maryland chapter presents the C. Lockhart Conley Award for teaching and education to a faculty member in the Maryland chapter. This award has been presented for over 30 years. I just want to say a word about Dr. Conley. Dr. Conley was truly one of the giants in the field of hematology. He was a faculty member at Hopkins for over 40 years. He was a renowned teacher, educator, and researcher, truly the triple threat back in the day when giants walked the earth. And Dr. Conley was one of the giants. He was as prolific as he was a researcher and as an academic professor at Hopkins. He always stopped to say hello. He always reached out to medical students, and it was his passion to teach residents. And many of the folks who trained with him still remember him very fondly. And so we are so proud here in Maryland to have had Dr. Conley as a member of the Maryland chapter when he was here, and that we are privileged to call this award name this award after him. So to introduce this year's awardee, I'd like to introduce you to Dr. Sam Kant. This award, I should just say, this award was vetted by the awards committee for our chapter, but we solicited nominations from residents and trainees, because they're the ones who experienced the teaching from the faculty here in Maryland. So Sam was one of those who were good enough to submit a very heartwarming and insightful, thoughtful nomination letter. Sam, I'm going to let you introduce our awardee this year.
Thank you, Dr. Chow. Well, I've known Dr. Jar for a number of years now, and having been one of his countless mentees who benefited from his kindness, I think it's an absolute honor to present this award to Dr. Jar. First, I must introduce Dr. Jar to give you a glimpse of how he continues to impact multiple institutions. Dr. Jar is an assistant professor of medicine in the Division of Nephrology, the Department of Medicine at the Johns Hopkins School of Medicine, with a joint appointment in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. He's also an associate faculty member of the Welch Center for Prevention, Epidemiology, and Clinical Research at the Johns Hopkins Medical Institutions as well. He also holds a Master of Public Health degree from Johns Hopkins and is a fellow of the American College of Physicians, American Society of Nephrology, and National Kidney Foundation. You could see how many institutions Dr. Jar continues to have a massive impact on. In addition, this is a long list, so please keep waiting.
He is the immediate past chair of the Medical Advisory Board of the National Kidney Foundation of Maryland. He's the co-chair of the National Kidney Foundation Education Committee and a member of the exam writing committee of the American Board of Internal Medicine, subspecialty nephrology. He is the chair of the State Maryland Commission on Kidney Disease as well. In addition to all of this, he's also busy practicing nephrologist with the Nephrology Center of Maryland. So you could see he's not only impacting number of institutions, but he's also impacting multiple patients and mentees. I have to also mention, it's important to recognize that he is also the recipient of the governor's citation by Governor Larry Hogan in 2017. And then in 2018, just recently, he was also given the Department of Medicine Award for Outstanding Achievement for faculty who are involved in a part-time position. I think in many ways this introduction would be incomplete if I didn't include a few comments from faculty and mentees that he has continued to influence over the years. Dr. Chow, in many conversations to me, has remarked that Dr. Jar represents the triple threat of academic medicine, just like Dr. Conley. He's also gone on to tell me that he is a consummate clinician, teacher, and researcher. Dr. Chow has personally had the opportunity of referring patients with renal disease to him for consultation. He's remarked that his clinical care is detail-oriented, evidence-based, and compassion-driven. He will not just make diagnoses, but teach house staff regarding underlying renal physiology, share relevant literature, and take the time to speak with family members. In the end, all of us continue to learn a lot from him every time patients have been referred to him. In many ways, he not only has a large referral base of generalists, but also nephrologists who seek out to him for advice and counsel regarding challenging cases. From mentees, Sorko, an internal medicine resident who was inspired to take up nephrology and eventually trained at Mayo Clinic, told me this. Told me a rotation with him gave me belief and self-confidence that I could be a decent doctor. He also had the humility to show me that even most experienced physicians have knowledge gaps, including himself, and it was essential to accept that and strive continue to improve. As for me, to this day, I continue to work with Dr. Jar, including last week in clinic, where I was amazed with how much he taught us. And believe me, I'm a graduating nephrology fellow, and the amount of knowledge that he bestowed upon me within a 4-hour period was immense. I have to say, since my early days of internship, Dr. Jar continued to be on the forefront for providing me advice for achieving my academic goals, and tirelessly aided in furthering them despite extremely busy clinic schedule. In addition, I'm also always amazed by his ability to simplify complex topics combined with an exemplary bedside manner second to none. As a trainee, still continuing to navigate the often meandering path of medicine, it is comforting to know that a mentor like Dr. Jar is continually watching over you. It is true, we are nowhere without our mentors. On behalf of the countless mentees that have been inspired by him over the years, thank you for all you do, Dr. Jar. I now present you Dr. Jar, the recipient of the Conley Award from the ACP Maryland.
Oh, thank you, Sam. I'm truly honored. I was amazed today when Dobbin called me. I thought he was calling me for patient care or discuss maybe a lecture or something else. When he told me about the award, I was taken aback, and I truly, for me, it's a true honor. It's exceptional. You know, walking on the footsteps of Dr. Conley, it's amazing. I want to thank the Maryland chapter of ACP and also the selection committee for this award. I'm truly humbled by this recognition. I'm sure there are several other very deserving colleagues who are also, you know, very devoted to teaching residents and fellows. But, you know, I believe that teaching is part of what makes us a very good physician. It's not only patient care, but also teaching the next generation of physicians. It's a true privilege and always a pleasure to teach the next generation. You know, but particularly when I can convert them to become nephrologists. I have a long list of former residents that have become nephrologists, and I stay in touch with them. And when we get together at the American Society of Nephrology, it's really a true pleasure. it's never too early to start become the next, teacher. And even as an intern or resident, I can encourage them to teach each other and to teach the younger physician that they work with, and to practice evidence-based medicine as much as possible. But I think in addition to teaching, what we want to make sure is also to teach the next generation of physician compassion, respect, equity, um, to be to have some empathy for the sick and the underserved population, particularly your patients that are, very sick or at the end of life sometimes. This is important for our profession. We are particularly at the forefront of patient care, and that part of our duty is as important as teaching knowledge, teaching medical knowledge, but also teaching those other characteristics of a good physician. And again, I want to take the time to thank the Maryland chapter of ACP and the selection committee for this award. Again, I'm truly humbled by it. Thank you so much.
Thank you, Bernard. I think I was amazed by the letters that we received on Dr. Jar's behalf, and there was one line that I won't forget. It says, "Dr. Jar is a generational talent in medicine," and I guess it rings true. We all come across many mentors and many great lecturers and speakers, but Bernard is truly exceptional. So Bernard, congratulations, well deserved, and Maryland chapter is so fortunate to have you as one of our members.
Thank you, David.
Now I'll turn the program back to Dr. Galati.
Thanks, Dr. Chow. Congratulations to Dr. Jar again. So we're going to take some time to acknowledge our Profiles in Excellence Awards. We're going to show a video from each of our programs. And before we do that, I want to say congratulations to the following profile awardees. From Anne Arundel Medical Center, Dr. Lily Walson. From the Greater Baltimore Medical Center, Dr. Anna Stark. Johns Hopkins Bayview, Dr. Robert O'Kay. John Hopkins Broadway, Dr. Tingia Lorangiano. I apologize if I mispronounced that. From MedStar Health Internal Medicine, Dr. Vashavni Rahman. From St. Agnes Accession, Dr. Ahmed El Aboude. From Sinai Hospital of Baltimore, Dr. Kerala Harari and in the Iques, again, apologies for my pronunciation. And from UMMC Midtown Campus, Dr. Isha Kumar. UMMC VA Campus, Dr. Pooja Patel. And Walter Reed, Dr. Samara Lieberman. We're going to go ahead and show a video from each of these programs.
Lily Walson is absolutely the definition of excellence in residency. From the very first day she arrived here, I realized I could count on her to always be a mentor for the interns and medical students who rotated with our service, and we couldn't be luckier to have her as part of our team.
There's a million different things that I could say about Lily, about how amazing she is. I was so lucky to have her as my senior, not only just throughout the whole year, but she actually was my senior in the first 2 weeks that I was an intern. She made us feel so comfortable. She was so understanding, such a great teacher. When you start off as an intern, it's a little bit nerve-wracking, and she really guided us and made the whole experience really amazing.
Lily is a natural leader and teacher, often leading by example. One of her greatest strengths is her ability to motivate her team members and provide appropriate oversight and expertise when needed. Her ability to allow junior team members an appropriate level of supervision is appreciated by both junior team members and faculty, and helps her junior colleagues in their professional development. And when you have Lily as your resident on your service, you know things are going to go safely and smoothly.
Her humble personality and caring nature touches the hearts of everyone she works with. During the first few months of my intern year, she worked with me repeatedly on tasks which I needed help with without being frustrated or rushing. She would not just tell me what to do, but rather listen to my ideas and how I wanted to approach them, and then help lead me in the proper direction. Even when I was not working with her directly, she was always very approachable and checked up on me whether everything was going well clinically and from a wellness perspective. She's a great role model for an upper-level resident, and I hope to be able to help my future interns and be there for them like Lily has been there for all of us this year.
As UVMC Chief Residents, Khadija, Maria, and I, Marwa, would like to nominate Anna Stark for the Excellence Award.
We thought of Dr. Stark being the most suitable for this role simply because of her excellent patient care, her need to make sure that the patients are safe on top of just managing their clinical aspects of care, her positivity and determination and also enthusiasm to make sure that residents are happy, creating wellness events, and just in terms of the chiefs just helping us out in everything that we need. She's always there to support us.
And this is only a small portion of the reasons that why we would want to nominate Anna Stark for this award.
So at the end of every block, we always talk to the attendees with the different clinical rotations. And I was talking to one attendee who worked with Robert about a month ago, and asked how Robert had done. And she said, "I just love Robert. Robert is amazing. Does everybody say that?" And I was like, yes, everybody says that. Robert is amazing, and has been for the entire 3 years that he's been here.
Robert is wonderful. I can't think of a more deserving candidate for this award. He's been awesome from day one. We're going to greatly miss him when he goes on to fellowship, but we love you here, and congratulations.
You're an amazing doctor to your patients, an amazing teacher to us, the intern class, and whoever meets you is always, I'm very grateful, and you bring such an amazing energy to every team that you're a part of. So I wish you the best, and thank you for being part of our team and our lives.
I've had the pleasure of getting to see him balance research presentations with emergency department duties, and just the agility that's admirable for any good clinician and any good doctor. Yeah, it's been a pleasure to be his co-resident.
And I think what really impressed me about him was the fact that he was always there and he was always available.
He's someone that I feel like everything could be crashing and burning around him, and he is just able to step into a situation and then just very calmly assess and address the situation. And so I love that about him. And I think the second thing is kindness. He is one of the kindest people that you will ever meet. Never has a negative word to say about anyone. He's always super positive.
It's such a kind senior. On my second day of residency, I had a corneal abrasion, and she forced me to the eye doctor and escorted me there, and didn't make fun of me once when I wore an eye patch for the next week.
Binja is an awesome resident. She's always very caring and always looks out for us.
Every attending I've met here has told me that they want to be Tinja when they grow up.
Yes! Tinja like ninja. I was here July, very beginning, started on the O with her. She called on me to read a normal sinus rhythm EKG. I blinked. She enthusiastically said, "It's okay, I got it," and she read it for me.
Tinja, you've been an exceptional leader for our interns, for all our house staff, and the entire house staff of the hospital. I can't think of anyone better who deserves to win this award. Congratulations, and thank you for being a role model and the infectious personality that you are. It's always a pleasure to work with you.
Tinja, you are a model of servant leadership. We are incredibly lucky
to have had you join us and to represent the OSA program and lead us through everything that you've led us through. And the fact that you're going to stay and help us lead even further, we are incredibly excited. Congratulations on behalf of the entire OSA program.
I'm so excited to get to say a few words about our winner for this year, Vaishnavi. Vaishnavi is just awesome, and she's not only an awesome doctor, she's an awesome human being and someone that everyone wants to work with. She's really a ray of sunshine and a really positive influence on all of our residency program. Vaish takes her job seriously. She always does amazing work. She's really been an inspiration, not only to her colleagues in her same class, but even those below her. She's been a very important contributor in our program evaluation committee, constantly bringing feedback from colleagues and just great new and innovative ideas. So I knew from the beginning Vaishnavi was going to be a star, and she's certainly not failed at that task, and we look to see what other amazing things she's going to accomplish. Congratulations, Vaishnavi.
It gives me great pleasure to say congratulations to Vaishnavi for this prestigious recognition. In addition to her great intellectual curiosity, she is a very kind, caring, and thoughtful individual and is a role model for all her fellow residents. Congratulations again, Vaishnavi, and I'm sure you will do very well in your future endeavors as a geriatrician and whatever else you decide to do along your career path. Congratulations again.
Just saw the latest ACP Excellence in Medicine Award, and what a great addition to it. Our own Dr. Vaishnavi Raman. Couldn't be more happy, and I'm not surprised. You did such a wonderful job this year. This was a tough year, and your resilience and your kindness and your subtle way of getting things done truly amazed me. And I think it was because you probably had a good family to start with. They gave you a lot of loving, caring support, or so you told me, and challenge. Pick the right IM medicine residency, good residents around you, good attendings, and a good focus on academic medicine, no matter how many times they took you away from the geriatric rotation. It really, really paid off, and I'm so happy for you. You make me think of a couple of quotes and one movie that I'd like you to see. The first quote is from my buddy Martin Luther King, who says, "The ultimate measure of a person is not where they stand in moments of comfort and convenience, but where they stand at times of challenge and controversy." And as hard as this was, you were able to take problems and turn them into solutions. You were able to make people around you comfortable. You understood people's vulnerability, and you gave them a lot of things that I'd love to have myself. You know, your kindness and then you're confident on top of that. What's up with that? And then the next one is something from me to you, and it comes from Voltaire, and it says, "Appreciation is a wonderful thing. It makes what is excellent in others belong to us as well." So thank you for the gift. You gave me a little excellence. I saw it in you, and I've got that. And the last one is the movie that I'd like you to see, and that's called Pay It Forward. 20 years ago, I saw this movie. It was about, I have to read this to you, this social science teacher who gives an assignment to a junior high school class to think of an idea that changed the world and then put it into action. And this little kid was amazed at what gifts he had, even more amazed how he spread it to others and how they appreciated it. I see you doing this in the future. I see a lot of other residents doing this in the future, and I can't wait to hear about what you've done and what you've accomplished. And I want to be, when I go into the hospital, demented and delirious, hoping one of you is there to help take care of me. And remember, don't forget to look at the abdominal X-ray. You know what it's for. Good luck with everything you do, and I will stay in touch because this is a good program and we follow those successful stories. See you later.
I would like to congratulate Vaishnavi on getting the ACP Excellence Award. I think she totally does deserve it. She is an amazing physician, colleague, and friend. She's very calm, attentive, and has a vast knowledge and very passionate about her job, caring to her patients. I have learned plethora of things from her on how to treat patients, how to examine, how to get the best out of a patient, and how to be a better doctor. In a sense, she is someone that I look up to. I feel she's a role model and a leader in her field. I remember the days when we used to work nights together. I feel comfortable coming into work, even though as being an intern, feel comfortable that she's there. You know, I have my back as someone who's knowledgeable. And she always took at least an hour, 2 hours a night just to educate me about things. She's going to be an amazing physician in the future and an amazing educator. I wish her nothing but the best, and she totally deserves this award. Thank you.
It's difficult to talk about Vaishnavi only in 30 seconds. She's a great resident. She's a very good person as well. At work, she's very humble, always shares work with the rest of the team. Personally, as a first-year resident, I felt very safe and comfortable when I worked with her at ICU Union. Thank you, Vaishnavi. I wish you all the best and best of luck in your next steps after residency.
He's the best cook ever. That's for sure.
I've known Ahmed since the start of residency. Ahmed is very studious. His interest in cardiology and research is very outstanding, and his publications can speak to such. I wish him the very best. Ahmed,
when you learn from your peer, it's really have a bigger impact, and I learned a lot from that. He is the excellent example of how a physician scholar activity should be. I learned motivation, hard work from him. I'm grateful that I had spent the 3 years with him. Congratulations, Ahmed. Well deserved.
Scoring so much goals in soccer.
When he comes over is he gets a lot of chocolates right here.
Stop it, Ahmed.
And worst moments, he gives me a lot of paperwork for his scholarly projects.
Ahmed definitely is very, very enthusiastic about his scholarly work, and he's always so passionate, and he makes you passionate about it. I love his energy and zeal and desire to always know more. And to
first, congratulations we got NCP customer from our program. And for the past 2 years, I learned meta-analysis from him, and I learned his workaholic attitude. Happy birthday! You didn't pay for it, man.
So when I think of Corella, I think of someone that's not just a really compassionate doctor, but I think of someone that's a really good friend. Anytime I needed assistance or help from her, she would be there. No matter how stressful the life gets, she never influences anyone else to be stressed, but rather for them to be calm.
Corella did not hesitate to help anyone, whether it's for her colleagues, friends, or even the community. Recently, we went out to the community to help with the vaccinations. and her selflessness and kindness was evident amongst everyone she came across.
If there was one word that I had to describe her, I would say it would be humble.
So what can I say about Corella? Corella is one of the most caring, dedicated, and hardworking physicians I know. She is the true definition of altruism.
Congratulations, Corella. You've always been known to be a team player, and you definitely deserve this award. Good luck in Boston.
Congratulations, Corella, my fellow Peruvian. I'm so proud of you. You deserve this award and many others. You're so great with all of your colleagues, and you take care of your patients so well. Can't wait to see all the great things you do in Boston. Good luck and congrats again.
Corella, congratulations on being chosen for this year's Profiles in Excellence awardee for Sinai. I can't think of a more deserving resident. We truly appreciate your generous spirit, your hard work on behalf of the patients. Again, congratulations, and we are so excited for you next year as you begin your nephrology fellowship in Boston.
Corella, congratulations to you. No one deserves this honor and designation more than you do. We know that you're going to continue to carry your good work and your outreach on as you go on to your nephrology fellowship and out into the world. We're so very proud of you, and I wish you all the best. Congratulations, Corella.
I'm really honored and grateful to receive this award. Special thank you to my Sinai family, to the Maryland ACP chapter, for my chief residents and my residents and my interns. I will dedicate this prize to all my patients, especially here at Sinai. Thank you so much.
Hey, so I'm very excited that Aisha is selected to be the resident to be profiled in this video. She goes above and beyond. She's very energetic, enthusiastic. She's passionate about patient care, and she's the go-to person for our nurses, our respiratory staff. She's so well respected throughout the institution. She helps out the program in ways that are, I think, a little bit under the radar, but she's sort of the underlying support that makes a program like ours go. So, could not be happier. Thank you.
Hey, congratulations, Isha, for being chosen as the awardee for the Profiles in Excellence Award for this academic year from Midtown. You deserve it. Your performance has been amazing for the whole year. And based on the feedback that we got from many students, co-residents, attendings, you have been selected by the chief residents to be the awardee for this year from our program. Thank you for being around. Midtown owes you a lot.
Hey, Isha. So
hey, Mehmet, what's up?
Yeah, so if we have a airway emergency, how can we look up the attending who will help us with those?
So you just go to the on-call, you hit search, and you go to see who's on call at Midtown. And when you hit that, you can see a list of all the ICU attendings on during the month right here, and you can see it with the calendar, who's the fellow and who's on as the attending during the day, as well as the weekend coverage.
Oh, that's very helpful. Thank you, Isha.
No problem.
the Walter Reed Internal Medicine Residency, they would tell you that Samara has the most stylish and organized desk. But Samara is also an innovator and a leader. Samara works to improve everything from hospital aesthetics to patient discharge summaries to small group teachings. We love and appreciate you, Samara.
Samara is one of the most dedicated and helpful people in our program. She's always there and willing to help out whenever you have any issues, questions, or in a bind. And I've been really grateful for all the help she's given me this year to grow as a PGY1, and I'm sure everybody else in our classes as well.
When I think about Samara, there are a few things that come to mind. Leadership, teaching, professionalism, and a good design eye. That's right. Samara, take life by the horns Lieberman, decided that she would augment the aesthetics of one of the medicine tea rooms and implemented a new, fabulous color scheme. If that ain't leading from the front, I don't know what is. Go, Samara.
So for someone like Samara, words just don't quite cut it, which is why we've invented poetry. So for Samara, for you, I have haiku. Natural leader. Really, really good at life. Mycology expertise.
To lead, you need Samara. No. I mean, you need two Samara. You need to be situationally aware, able and willing, motivating, approachable, reliable, and laudably ready. Thank you, Samara, for the example you set.
Samara is an amazing leader. She led a team that improved the way discharge summaries are written for all the patients discharged from our hospital. She also led a team to renovate one of the team rooms, and it looks much better now, so thank you, Samara.
Congratulations, Samara. I can think of no one more deserving than this award than you are. You bring an incredible amount to our residency every single day. You're an amazing teacher, leader, clinician, and most of all, I think that everyone who works with you is able to draw from your positive energy. Again, congratulations on this award.
Congratulations to all of our Profiles in Excellence award winners. This year, given the fact that this past year was a COVID pandemic, we thought it was especially meaningful to add a COVID Warrior Award. Here are our awardees, and I'm going to say a little bit about each of them. Mercy Hospital, Dr. Joseph Costa. Dr. Costa was a graduate from the University of Maryland Medical School. Their residency, fellowship programs, and for many years was our medical director of the intensive care unit here at Mercy Medical Center. As the pandemic raged, Dr. Costa continued to take care of our sickest patients and fill additional shifts in the ICU, all of the while continuing to be a part of the leadership here at Mercy as we plan for the growing and unknown stresses of our situation. With little regard for his personal safety or his increased risk of infection, he provided exemplary care. Tragically, Dr. Costa contracted COVID and ultimately lost his battle with the disease while a patient in the ICU where he had spent many months and years practicing. He was much beloved by the entire team. MedStar Health, Dr. Calvin Williams. Dr. Calvin Williams is a member of the internal medicine faculty. In addition, he provides inpatient infectious disease consults. He is involved in antibiotic utilization as well as infection control at MedStar Union Memorial Hospital. He completed his medical school at the University of Maryland Infectious Diseases. St. Agnes Accession Hospital, Dr. Dante Soffridi. Dr. Soffridini is a great teacher and a mentor. He gives his patients hope, encouragement, and insurance. He has such a strong work ethic, and as an ICU attending, he is very humble, compassionate, and kind. He is honest and explains the current situation of every patient to their family members in a way that's easy to understand and an explanation so they can help with making tough decisions for their loved ones. If you heard his name, The first thing you will think, he is that awesome ICU doc. He is loved by all of our residents from the heart. He always encourages and helps residents to pursue their dreams in their interested fields. From Sinai, Dr. Sahib Singh. Dr. Singh is a current PGY3 resident at Sinai. Following his residency training, he will serve as chief resident at GBMC. He was selected as this year's COVID warrior due to his efforts to support patient care and advance our scientific knowledge of COVID. During the spring of 2020, when COVID was at its initial peak in the Baltimore area, the surrounding areas of Sinai were hit really hard. The ICUs were overwhelmed. In particular, our affiliate institute, Northwest Hospital in Randallstown, saw a specific rise of COVID cases. In response, the chair of medicine requested additional support in the COVID unit, and Sahib was among the first to volunteer. He worked alongside our pulmonologists and critical care staff to assist in the care of seriously ill COVID patients. As the surge subsided, Sahib worked with a COVID research team led by our cardiologists and pulmonologists. Specifically, the projects he was engaged with examined the prevalence of hypercoagulable states among patients infected with COVID-19, as well as a cohort study on the effectiveness of various treatments of COVID-19. At Sinai, both the medical professionals and patients are grateful to Dr. Singh. His contributions to patient care and medical science during the COVID pandemic are unmatched. Walter Reed, Dr. Erica Walker. Dr. Walker is our chief hospitalist. She demonstrated extraordinary leadership and resilience during the start of the pandemic and continues to provide stewardship throughout these challenging times. Dr. Walker helped stand up COVID-19 isolation unit at the beginning of the pandemic, personally training nursing staff and medical residents on proper precautions and the care of COVID-19 patients. She personally took to the front lines and volunteered to lead the COVID-19 response, despite the unknown risks to her person and families. In addition, on the internal medicine wards, she modeled bedside manner and compassionate care during challenging and terrifying times when patients are separated from their families and loved ones. As the pandemic evolved to be part of our daily lives, she continued to lead the evolution of Walter Reed to find a durable solution to inpatient management by setting up an enhanced precautions unit. She continues to be a crucial liaison between hospital leadership, our COVID-19 research team, and our internal medicine program. She has displayed selflessness throughout and modeled position leadership in crisis. She has an undeniable, tremendous personal impact on each of the internal medicine trainees and anyone who has been part of the COVID-19 response at Walter Reed. Congratulations, and with much gratitude to all of our COVID warriors and all of us who have served in this past year of the pandemic. Now it's not time to announce the winners of our second virtual residents meeting. I'm really excited to share all of these winners, and I want to make sure that everyone is aware that you will be receiving a plaque for all your wonderful achievements. And again, thank you for taking time to find these cases, share them with all of us, and for putting all these presentations together. We're going to start with the research poster. And in the research poster, the first place goes to research 3, which is Dr. Vinod Solipuram, the effect of JAK inhibitors and methotrexate combination on the risk of malignancy in patients with rheumatoid arthritis, a systematic review and meta-analysis of randomized controlled trials. Second place, research poster number 16, goes to Dr. Abera Usman, the use of metformin in patients hospitalized with COVID-19. And third place, research poster number 7, is awarded to Dr. Zachary Haynes from Walter Reed, obstructive sleep apnea after traumatic injury. An honorable mention goes to research poster number 1, Dr. Gayatri Nair, improving vaccination rates in resident continuity clinic using quality improvement measures. Congratulations to all of the research poster winners. Now we're moving to the clinical vignette awardees and winners. In first place, Clinical vignette number 85, Dr. Rawan Amir, culture negative late prosthetic valve endocarditis, unmasking and unusual diagnosis. Second place, clinical vignette number 121, Dr. John Preston Claiborne, hemophagocytic lymphohistiocytosis secondary to suspected SARS-CoV-2 infection. Bit of a tongue twister there. Congratulations. And third place, clinical vignette number 188, Dr. Sanjeev Vani Shastricha. Would you like some iced tea? A case of oxalate nephropathy. Congratulations. And 4 honorable mentions for the clinical vignettes. Clinical vignette number 29, Dr. Jyotsna Josh, agonizing hip pain with high synovial fluid WBC counts. Clinical vignette number 44, Dr. Daniel Soldin, dapsone-induced methemoglobinemia and hemolytic anemia. Clinical vignette number 96, Dr. Alex Avasano, I'm having such a tongue-twisting day today. Mucinous adenocarcinoma of a sigmoid vaginoplasty in patients with Meyer Rokitansky Kutzer-Helser syndrome and Lynch syndrome. And clinical vignette number 151, Dr. Michael Orick, Walter Reed, triple negative breast cancer screening as palmar fasciitis and polyarthritis syndrome. So congratulations to all of you. Many, many thanks and congratulations again.